Hi, I'm Betsy Nicoletti. Thanks for joining me today. We're going to talk again about coding for behavioral health, once again with feeling. You might remember that last April, in April 2022, I recorded a video about coding and compliance for behavioral health services, but we're back at it again. And why are we back at it again? Because the OIG is back at it again. So back a year ago, the OIG audited one individual provider, psychiatrist, who they said was one of the highest billing providers in the country. So that's one type of audit. The audit that they did this year in May, reported in May of 2023, was about psychotherapy services, but it was a number of different providers. They didn't focus on one practice. And some of these were during the pandemic. So there's a few findings about the pandemic, not too many. So here are our citations. You know, at Coding Intel, we believe we've got to give you the source citations, and it is the OIG reports if you want to read them for yourself or want to read part of them for yourself. You can just Google OIG and those numbers and they'll come up for you. So this year, they found, shockingly, that psychotherapy time wasn't documented in the medical record. And this is really just a basic thing for coding. If the code is defined by time, like psychotherapy or critical care or physical therapy, you've got to put time in the medical record. It's not enough to just put the time in the description of the code. Some treatment plans were incomplete or missing. We're going to talk about that. Psychotherapy, no psychotherapy was provided or documentation was missing. Well, if there's no documentation of it, of course, we can't expect to get paid for it, or it was incomplete documentation. And then a few things about an incorrect number of services, billing for 2 sessions of psychotherapy in a single day, or an incorrect code. And then there's always our favorite incident 2 requirements not met. So time spent in psychotherapy has got to be documented in the medical record. CPT, neither CPT nor Medicare require start and stop times, but check your private payer policies, but you've got to state the time. And be a little bit careful of your medical record, because recently I reviewed some notes where the clinician had said X minutes, but it was a telehealth visit, and the time in and the time out did not match what the clinician had said. So we want the clinician to tell us how much time they spent. And it's insufficient if you just select the code and the code describes it as 30 minutes with the patient. The other thing you don't want to do is use the appointment time, because appointments don't start and stop at the moment. So it's not going to pass muster in an audit if the appointment time is listed up there and it says 30 minutes and that's all that's documented, because all visits don't start and stop at the right time. They're not all 30 minutes long. So here's what the OIG said. And before I read that to you, you notice there's some LCDs listed at the bottom, where what Medicare did, what the OIG did, was they went and looked at individual MACs, local coverage determinations for psychotherapy. And they're quoting those here. And we have a 2-page summary from the OIG report available for you to download. I'll talk about that at the very end. So the individualized treatment plan must state the type, amount, frequency, and duration of the services to be furnished, and indicate the diagnosis of or mental health disorder or disease, anticipated goals of psychotherapy treatment. So the treatment plan has to say what you're treating and how you're going to do it in a few words. A periodic, and I don't mean in a few words in a treatment plan, I mean, I've taken that first sentence and made it into a few words. A periodic summary of the treatment goals, progress towards that goal, and updated treatment plan must be included in the medical record. Personally, when I work with groups, I say, for long-term care, let's do that periodic summary quarterly. So some of these visits didn't pass muster with the OIG. There was no treatment plan, or the treatment plan didn't have the type, frequency, or duration. And then this must have been the same. For 2 enrollee days, the medical records included initial treatment plans that were established 6 and 8 years before the sampled encounters, and updated treatment plans weren't included. So we go back a slide and we look and say, we've got to have a periodic summary of the treatment goals, progress toward those goals, and an updated treatment plan. So from 6 and 8 years ago, that's not going to pass muster. What is the time frame? No one says, oh, if it was 1 year ago, you don't have to redo it. But again, when I'm working with groups, I say, if it's a long-term patient, let's review those plans and goals quarterly and progress towards achievement of the goals. For some notes that they requested, the OIG said the documentation didn't support psychotherapy, or no documentation was submitted. And now this is a big, we're not going to do this. For 7 enrollee days, the providers furnished documentation for the sampled items. However, they created the documentation after we had requested the medical records, which was more than 8 months after the sampled enrollee days. You know, if we were doing emojis, it would be the emoji with the hand on the forehead. Of course, we cannot create documentation 8 months after the date of service. Maybe there is someone with a super memory who really can remember what happened at that specific visit 8 months later, but it seems unlikely, and the payers are not going to accept it. We never create documentation after we've received a request from a payer. We never create it afterwards. So here's from the report, from the OIG report. The medical record documentation maintained by the provider must include a detailed summary of the session, including descriptive documentation of therapeutic interventions, such as examples of attempted behavior modification and supportive interaction. So take this sentence to heart if you are reporting a medication management service with an office visit code and psychotherapy. Because often when I look at those notes, I see the medication management documented, but I don't see the psychotherapy documented. You're being paid the same amount for that psychotherapy. It has the same RVUs as a standalone psychotherapy. And if you want to get paid for it, you've got to document it, a detailed summary of the session. And then everyone gasped. Have you gasped? Medical records must document the patient's capacity to participate in psychotherapy if psychotherapy is in the chosen treatment. So first, they found that sometimes the therapy wasn't documented, and then they're looking for reasonable expectation for improvement in every session. So that's my next question. At every session, are we going to say that there's a reasonable expectation that the person is going to improve? For 6 enrollee days, providers did not document that they were expected to improve. For 4 enrollee days, the providers, and that just means for 4 encounters, the providers did not include in the medical records a periodic summary of goals or progress towards goals. And for 1 enrollee day, the provider did not document the enrollee's capacity to participate in the psychotherapy. So again, I'm asking myself, do these things need to be documented at every encounter? What is the OIG thinking here? My recommendation is these are things that should go in the treatment plan, that the patient can be expected to improve, that they can participate in the therapy. And we're going to have the treatment plan is going to include goals. And then quarterly, we're going to put into the encounter for the day that the goals and the progress towards the goals. And I think if you're asked, based on this OIG report, If you're asked to submit records for psychotherapy and the individual encounter that you're asked to submit doesn't have the treatment plan, I would send the treatment plan when it was dated. So just, that it's going to show the date that you did the treatment plan. It's going to show these things that the patient is expected to improve, has the capacity to participate in psychotherapy, and then maybe the most recent update on progress towards goals. And try not to have the goals be so generic that they're the same for every single patient. You don't notice it if you're looking at one note, but if you're looking at 10 notes, I know we have a lot of templates, and I know we don't want everybody to be typing all day long, but we want these to be individualized. And then services not meeting incident 2 requirements, the physician or whoever, or the psychologist, whoever we are billing under, and who can we bill incident to? We can bill incident to a physician, nurse practitioner, physician assistant, certified nurse midwife, maybe not relevant for psychotherapy, and a psychologist. So the provider who is doing the billing, under whose provider number we're submitting the claim, has to have seen the patient first and initiated the plan of care. So if you're billing a social worker incident to the psychiatrist must have seen the patient first, initiated the plan of care, stay involved with the patient, and be physically present when the service happened. Otherwise, bill it under the social worker's provider number. And then, I don't know quite, this is no surprise to anyone. They looked at the modifiers that were submitted with the claims and with place of service. And even though we're not to be using place of service 02 right now, some of them were submitted with place of service 02. As we speak in July of 2023. So if you're listening to this in the future, just remember when I'm recording it. And what they found, and then they surveyed those clinicians and asked if they had been done via telehealth or not. So they did find that there were services provided as non-telehealth services and billed as telehealth, and vice versa. So we want to be really clear when we're billing for telemedicine that it was a telehealth service, and if it was audio and visual, or audio only. We want to make sure that that is clear in our records. So the CMS did provide this 2-page overview of the MACs. Not every MAC has a local coverage determination for psychotherapy, but the OIG produced this 2-page overview. It was very nice of them to do that for us. You can download that in the link. If you're watching this on Coding Intel, you can download it right on the page that you found this video. If you're watching it on YouTube, there's a link that's going to take you where you can download that 2-page overview. Personally, I thought it was a great comparison, and I was grateful for the OIG for doing it. And I would suggest, if you're doing behavioral health, it might not be a bad idea to look at that April 2022 video for a little bit more guidance. So again, once more with feeling, sing along with me. Document time for psychotherapy. Sign your notes. There were some notes that the OIG found weren't signed by the clinician. These were handwritten notes. I think mostly our EMR notes are signed now. Famous last words, right? Develop a treatment plan, and that should include goals, and update that periodically. Progress towards goals. My recommendation: include in that treatment plan that the patient is able to participate in and benefit from therapy. If it's an E&M service in psychotherapy, so it's a psychiatric nurse practitioner who's doing medication management and also providing psychotherapy, make sure you're documenting the time of the psychotherapy only, not the total time of the visit. The OIG found that as an error. And then go back to that slide where the OIG said things that needed to be in the note to support psychotherapy. And remember, that note for psychotherapy should stand on its own. And even if it's part of the E&M service, that portion of the note should stand on its own to support the payment for the second service. All right, thanks for joining me today. And I look forward to seeing you again at another one of these sessions.